Hi, it's Dr. Centeno, and thank you so much for joining us today. All right, you've got the power. I'm going to start something a little bit new today. Going to get into uh, the concept of diagnostic accuracy, and this applies to lots of things: craniocervical instability, which we talk about a lot on this show, intracranial hypertension, tethered cord, et cetera, on and on. Each one of those diagnoses has a certain accuracy associated with that diagnosis. Now, I didn't expect to be on today, but my brilliant assistant was able to move some things around in my day so I can head to the airport after this. So we'll be done here at around an hour because I've got to head to the airport. But again, if you're just joining us, we're talking today about diagnostic certainty and how certain can you or your doctor be that you really have a certain diagnosis, whether that's craniocervical instability or whether that's intracranial hypertension or whether that's tethered cord. How do we know that's what you have? And it's an extremely important situation and concept, especially when we're talking about uh, problems that are hard to diagnose, meaning we don't have a single blood test that we can give you, for instance, that diagnoses tethered cord. We don't have a single MRI image that we can use that has high diagnostic certainty to diagnose tethered cord or craniocervical instability. So, how do we get there? So let's talk about that. I'm going to focus today on craniocervical instability. I'd like to, in other talks, talk about other things and other diagnoses. But to try to introduce this concept, I'm going to focus on imaging in craniocervical instability. Now, you can ask questions at any time, and that's using the comments. You can ask questions about this topic. You can ask questions really about anything at all. It doesn't matter. So I'll get into a short lecture. This one's going to be a little bit more intense because I'm going to introduce you to some concepts that are critical concepts in medicine that in order to protect yourself, you really want to understand these at some reasonable level. So let me share my screen here and I will start with, there we go. So I'm going to start with a lecture, again, a little bit more intense than we normally do, but I think you guys are ready for it, right? We've been talking about some interesting things here, and I want to make sure that you guys can get into this. Now, I've got a super wide screen, so I'm going to have to change my screen setup just to make sure. Well, maybe I don't want to do that. So I think we'll go with this because I want to be able to write on the screen. So we're going to start with the concept of which imaging measurements can accurately diagnose traumatic craniocervical instability. Now, you would think that this is easy, right? But one of the hardest things for patients to understand is this concept of diagnostic accuracy. I think all patients believe that for the most part, when a doctor renders a diagnosis, it has high accuracy, right? There's little chance that the doctor is wrong. However, it doesn't matter who's rendering the diagnosis, a physician, a surgeon, a neurosurgeon, orthopedic spine surgeon, doesn't make a difference. All diagnoses that are rendered by people and humans have a false positive and false negative rate. So what does that mean? A false positive is a test that shows you have a disease, but in reality, you don't have that disease. And a false negative goes the other direction. That's a test that shows you don't have a disease, but in reality, you do have that disease. Now, this happens all the time in medicine. And in fact, we doctors talk about this all the time. What's the false positive rate of that test? What's the false negative rate of that test? These are important concepts for doctors, but they generally aren't thought of a lot at the patient level. So the problem is, what's the likelihood that a diagnostic finding, a specific diagnostic finding, is causing your symptoms? Um, and this is one of the key concepts here. Just because you have some sort of measurement, doesn't matter if it's an elevated pressure on a spinal tap or a specific measurement that was taken off your MRI. The big question you've got to answer, and your doctor has to answer too, is what's the likelihood that that measurement or finding is causing your symptoms? And that likelihood could be thin, meaning that we're not really sure, or it can be more substantial. We're pretty sure that that's causing your symptoms. Now, notice I use the words sure, or pretty sure, or kind of sure, or very sure. And this is where patients sort of get lost because they believe many times that just because a certain measurement, and today we'll be talking about CXA or clivo-axial angle, is abnormal, that must be causing my symptoms. When in fact, as I'll show you, we've got very little research that anything having to do with your clivo-axial angle has anything to do with your symptoms. So this is a key concept that is critical to understand, that there's this thing called diagnostic accuracy, and a measurement and your symptoms may or may not be related. So, for example, we know that in routine MRI imaging of the neck and back, it's pretty bad at predicting which patients have neck or back pain. Now, there's some specific findings that are better at that, but in general, there's lots of patients with normal MRIs that have neck and back pain, and lots of patients with awful looking MRIs that have no neck or back pain. So right there, we start to see this disconnect, which is well known in medicine, between images and symptoms. So let's review this concept. Now we're going to focus in a little bit on the idea of what I would call, for lack of a better term, chronic CCI. So what is that? These are patients that have upper neck instability, but they're not in a situation where emergency surgery has to be performed. That's a different kind of CCI. That's an upper cervical fracture, or someone that gets into a huge car accident where the person sitting next to them was killed and their head is hanging on by a thread and they've got to get emergency surgery. Or a rheumatoid arthritis patient who hears a clunk because their dens has been destroyed and now their spine is literally indenting their spinal cord by half of its width. So we're not talking about that. We're talking about the average CCI patient who is relatively disabled from upper cervical instability, but doesn't need emergency surgery right now. And so this patient population that we're discussing is often offered a fusion based solely on some measurement. And I've got to make sure this isn't someone trying to get in touch with me. Based solely on some measurement found on their MRI. So now, yes, there might be sort of a small, very quick exam in there. Maybe there's another piece to this puzzle, but many times it's this finding on that person's MRI leads to surgery. So because we're putting so much stock and trade in this MRI measurement, we've got to be absolutely certain that the diagnostic accuracy of that being found on an MRI is directly connected to symptomatic CCI. And I'm going to make a statement here because I've done the research on this. And if anyone out there knows of other research I'm not looking at, please send it to me because I'd be happy to look at it. But these measurements have poor scientific support in classifying patients into symptomatic chronic CCI and not symptomatic patients or asymptomatic patients. So grab oaks, that's a big one, right? You hear about it all the time. We have very little data that shows that an abnormal grab oaks is associated with symptoms in this patient population. You hear about these all the time, right? BDI, BAI, static BDI, static BAI, translational BDI, translational BAI. Again, poor research connecting those abnormalities to symptomatic CCI or chronic CCI. Clivo-axial angle, and it's got lots of different names, also called a CC or CCA. Again, poor connections. So we're going to go through this concept, and I'm going to focus today on clivo-axial angle because I can go through that research relatively quickly. And this is one that's used to define whether or not someone has cervical medullary syndrome and consequently needs surgery. Now, here's a concept, right? I just went online, I went on Google, I typed in clivo-axial angle, a page came up which had 3 different references, basically stating that if you had a clivo-axial angle under 135, that was an abnormal finding indicative of CCI or craniocervical instability, or in this case, right, symptomatic or disabling CCI. So we're going to take someone who has a clivo-axial angle 5 degrees less than that of 130. But we're going to ask them important questions. We're going to ask how many people are walking around out there with no symptoms and who lead a normal life that have this measurement. And then we're going to ask another question. Can a CXA 130 correctly pick and put people into the right bin? Meaning that if all we knew was the CXI and we had 2 bins, right? Maybe I'll put my bins down here. Sorry, guys. So we have 2 bins, one being symptomatic CCI and the other just being normal patients. We're going to expect that a very high amount of the time that 130 is associated with symptomatic patients, and almost nobody in the normal cohort has anything near a 130. So let's look at that. And just so everyone understands what we're talking about, the clivo-axial angle is really the angle of the skull on the upper cervical spine. So if the angle is low, the skull is forward. If the angle is high, the skull is backwards. Now, for a low clivo-axial angle, the concept is, at least theoretically, is that the dens here is going to push more into the brainstem and upper spinal cord here, brainstem or medulla there, and or this is going to be draped over that in such a way it's going to put pressure on there. So this is also called cervical medullary syndrome. A lot of times this is called MECFS. We've got other things it's associated with, like Chiari syndrome, where the back of the brain is hanging too low, et cetera, et cetera. So I'll call these patients chronic CCI. Now, for the CXA of less than 135 to be scientifically valid as a measurement that can put people into one of those 2 boxes with just that, we'll need a study performed on patients with chronic CCI, i.e. not neurosurgical emergency cases. And that study needs to have chronic CCI cases in normal control patients. Can't just have chronic CCI patients because we're going to need to see what the normals have. And it has to report the accuracy, again, of placing them into those 2 boxes. How many times are you going to be right with a CXA 130, and that's all you know, that you found a symptomatic CCI patient? And these are the 3 studies that were quoted online as being authoritative in this concept that an abnormal CXA is lower than 135. One was this study called, I'll call it Bothello. Another one was Batista. Another one was Brunshu. So those are the 3 studies that were quoted. And I'm not going to get into too much of the weeds here on these studies, but I'm going to go through a little bit about what they found. So Bothello, this study focused on severe neurosurgical cases. Most of these cases had what's called obvious basilar invagination, where the brainstem was severely compressing or getting severely compressed, so much so that it dramatically changed in shape. It did have some normal patients, so that's a thumbs up for Bathello. So we'll put one arrow up here. And it did, of the three, this is the only study that had anything close to chronic CCI. They had some Chiari malformation cases who they thought were surgical candidates. And in these cases, the brainstem was just merely being touched by the den. So that's pretty much what we see in most of our chronic CCI patients. The problem is when they looked at those chronic CCI type patients, there was no difference between the clival-axial angle, they called it the CC instead of the CXA, between the chronic CCI or the cervical or the Chiari malformation group here and the control group. Meaning that even though this study, Bathello, was quoted as supporting a CXA less than 135 could accurately diagnose chronic CCI patients, it didn't really do that, because in that patient population, there was no difference in the clival-axial angle between our CCI type patients and the normal controls. No difference at all. Now, Batista is good on the one hand, that it looked at lots of normal CT scans, so that's great. And the clival-axial angle was measured from 132 to 174. So now our 130 comes in just slightly above the lowest one that they saw. So not super convincing that Batista is going to get us to less than 135 is abnormal, because it had people with the 132 on the low end. But the biggest problem with Batista is no chronic CCI group was included at all. So we have no idea what those measurements would have been if we were trying to use them to put people into the right bucket. Do they have chronic symptomatic CCI, or are they a normal patient? Wasn't done at all in Batista. Now, Brunshu was just a total mess because it's in chronic rheumatoid arthritis patients where the dens just turns to mush. And I've never seen a chronic CCI patient in my practice, and I've had lots and lots of these patients, that has that finding. So Brunshu shouldn't even been in this list trying to figure out if a chronic CCI patient had an abnormal CXA at less than 135. So how much hard scientific data do we have that a CXA of less than 135 can accurately identify who has CCI and needs surgery? Not much. Two of these studies didn't even include that population, and the only one that did include a population kind of like that found no difference in the CXA between symptomatic and normal patients. So now let's look at how this should be done. And that's what Freeman and Katz did with these DMX measurements. And we're going to focus on one of those DMX measurements, just like we just focused on one of the neurosurgical measurements, and that's C1, C2 overhang, or how much C1 goes sideways on C2. So that's what we're going to look at. So basically, Freeman and Katz defined that if you had a C1, C2 overhang of more than 4 millimeters, if you include other things, you can probably get that down to 3 millimeters, but we'll go with 4. So how did they conclude that? Did they do what the other guys did and just looked at a bunch of normal patients? Or they do it the right way, where they tried to use this measurement to put people into the symptomatic or the normal bucket without knowing who goes in those buckets and the accuracy of that choice? Well, they did it the right way, which is they looked at 119 car crash victims that had chronic neck and head pain. They looked at 77 uninjured controls. Then they had blinded readers that didn't know who was in which bucket. And they used those measurements to try to correctly classify people into the buckets. Now, already, this Freeman-Katz study is higher than any that exists that I've seen for any of the neurosurgical measurements we've talked about today. It's a higher level study. Certainly, we can say that they did it the right way because they included a group that's most likely to be the CCI patients that we see on a day-to-day basis. So that's a check mark. They did try to put them into buckets, right? So they tried to classify these people. And then they looked at the diagnostic accuracy of various measurements. Now, I haven't seen a neurosurgical study that has done that yet on those measurements, but if you can find one, again, please send it to me, and I'm happy to look at it. So they used these two numbers. They said, okay, let's try 2 millimeters and see if something over than 2 millimeters allows us to put those patients in the right bucket. The good news is they correctly classified the injured patients 64% of the time, but they had a high false positive rate. So about a third of the patients who were normal had about 2 millimeters or just above 2 millimeters. So that's not a great number to use. So then they increased it to 4 millimeters, and that totally changed their false positive rate now to 5%. So it was 95% accurate in putting people into one of those two buckets. So now a completely different world than what we saw with the CXA studies. And that's the problem with those neurosurgical measurements, is that I've seen none to date, but maybe there's one out there where people have done this kind of thing about classifying patients based on certain measurements. If a BAI, translational BAI, is more than this, how does it correctly classify symptomatic and asymptomatic patients, etc.? So I'm going to wrap this up. This is the same discussion that you all should be having for every measurement provided to you that seems to prove that you have CCI. Now, listen, sometimes clinical diagnoses are made in medicine, and that's based on your physical exam. We've talked about that. That's based on your imaging, how you got this, on and on and on. But if we're going to rely on a measurement to do something as big as surgery, we should certainly know how many normal people out there have this measurement and what's the accuracy of that measurement in finding symptomatic people and separating those out from normal controls who are just walking around out there. So let me go to questions now. I know that was a bit intense and a bit long, but I want to start introducing this concept of diagnostic accuracy because I think it's really critical in CCI and lots of other cases as well. So let me stop the sharing here, and we'll discard that, and we will go to questions and see where we are here. Let's see here. Hi, Sarah, patient at Dr. Bashir's. Liam, is there a particular measurement value for C1C overhang where you begin to think that it will take multiple PICLs for symptom improvement? What's the value? And it's not that straightforward. Not really that straightforward, Liam. I would say that in general, what we tend to see is about a 25% reduction in overhang per procedure. And that's in responders. So let's say you're a responder and you have 6 millimeters, right? So if we take 25% of 6, so let's say after the first procedure, you go down to about 4. And for the second procedure, you go down to about 2.5. And the third procedure, you go under 2. So now all of a sudden, you can see that if you've got a 6 millimeter overhang, it's going to take about 3 procedures or so. Obviously, everyone's different to get where you want to go. Now, that would be less if you had a 4 millimeter and more if you had an 8 millimeter. That's kind of how all this goes. Liam, is there a particular measurement value for neutral ADI and for dynamic ADI and flexion that applies enough transverse damage for you to include it in the PICL? Yeah, that's a whole other topic, Liam. Probably a good one for me to cover because it's a little bit more complex than that. Usually there's been considered something called a rule of 2, that more than 2 millimeters in a measurement like ADI would be associated with transverse ligament laxity. However, the CAT study that we were just talking about really looked at that differently. So it's a little bit more complex, but suffice it to say that if we look at all your images, we'll talk about that. And I'll probably do a video on it to kind of help some of that complexity. Sarah, Dr. Joel Frank diagnosed me in 2019 with CCI and 10 millimeter synovial cyst by my brainstem from ruptured ligaments. Atlas is canting downward and small anesthesia of CO2 over C3. PRP didn't help. Yeah, Sarah, I don't know what you had with Dr. Bashir or what he tried to treat. These days, for something like that, we do a PICL procedure. So that would be bone marrow concentrate from the front, getting the transverse and alar ligaments. So that's going to be pretty different than anything Dr. Bashir did with you, but I don't know what he did. Sarah, neurosurgeons need to do more dynamic imaging. Yeah, I would agree with that, Sarah. I do think that we're starting to see more neurosurgeons who specialize in CCI do more dynamic imaging. I think they're starting to get into flexion extension, MRI. I know that Dr. Frank uses a lot of DMX. So we're seeing that. But you're right, the standard neurosurgeon is not using a lot of dynamic imaging, and that can cause some problems. Lauren, Dr. Centeno, you're the best. You help so many patients to get real long-term pain relief and help patients avoid more invasive surgery. So grateful for you and what you do to help people. Thank you for everything you do. Oh, Lauren, thank you. Very, very nice to hear that. Certainly at the end of a long week, very nice to hear. So thank you. Sarah, that's me, CCI for 9 years. Yes. Pia, did 3 studies make sure to exclude patients with control groups with any neck complaints? Yeah, Pia, well, that's a good question. I'll have to look back at the studies, but I think the problem there that you're bringing up is a good one, and that is what percentage of patients who just had neck complaints would have CCI. Now, that would be a very small number anyway. We're talking less than 1%. So I think there'd be little risk of just including people who went in for a neck MRI to look for something like a herniated disc in their neck. So probably that's not going to move the needle on that data very much, since the prevalence of CCI is so rare in even the neck pain population. Nick, as provocative testing goes, does doing shoulder presses with no weights commonly produce CCI symptoms? For example, if I do shoulder presses with just my arms, no dumbbells or extra weight for only 3 sets of 15, I'll have pressure on my upper left cervical spine, bad headache, nausea, difficulty focusing, which lasts for hours. You know, Nick, the answer is that's an interesting one, and I think an important one to bring up. And that is, let's look at that for a second. So if you're doing shoulder presses or reaching above, what does that do? Well, that engages, among many other muscles, your upper trapezius. Now, why could that potentially be a problem for you? Well, what we see in a lot of CCI patients and neck instability patients in general is that the upper traps, the scalenes, sternocleidomastoids, the big muscles out here recruit in order to try to substitute for the inner stabilizing muscles that aren't working. So if you've got your arms down like this, your upper traps are working to help stabilize your neck. But if you use them and you go to lift your arms above your head, now all of a sudden you're using your upper traps to lift and help lift your arms. So they can't be available to stabilize your neck. So that's a common thing that we hear from patients who have CCI or any kind of neck instability. When I try to work overhead, that will cause me problems. And the reason is that you can no longer use that upper trap as a stabilizer for your neck because you're using it to help lift your arms. So that's a pretty common one we hear. Ryan, I had a thoracic angiogram MRI showing complete occlusion of the subclavian artery on my right side between the scalene and the clavicle. In your experience, could this be downstream caused by CCI or vice versa? That's a good question. Basically, kind of getting on to what we just talked about, and that is that the upper traps, the scalenes, the sternocleidomastoids are frequently recruited by the body to provide neck stability. The scalenes are almost like sailboat mast guy wires. They come down and they help to stabilize. So again, in not only CCI, but any kind of neck instability patient, the scalenes are going to be working overtime. Now, those veins go through the scalenes. So if the scalenes are working overtime, then you could see intermittent occlusion of the scalenes because they're doing a job they weren't designed to do. And if they do that for a long time, they're not going to be very happy about the whole thing, meaning they're going to be in chronic spasm and chronically overworked. So that all makes sense to me, that's one mechanism for why that would happen. Thank you, Nick. Ryan, subclavian vein. Yeah, so again, that's called thoracic outlet syndrome, and probably worth just talking a minute about thoracic outlet syndrome since that's so common in this patient population. So I'm going to go and pull up some images here that may help everyone understand what we're talking about a little better. Let's see here. Yeah, this is a good one. Okay, so I'm going to just put this image in a PowerPoint so we can blow it up. Again, I'm going to talk a bit about thoracic outlet because it's so common in patients with lots of different neck issues, not only CCI. And I think it's important, therefore, to discuss. Well, I can't say this is the best image on earth, but we will go with it anyway. Yeah, you guys can see that. So anyway, thoracic outlet. So we have a couple things here that are happening with thoracic outlet. I'm actually going to share my whole screen so I can use the Okay, so thoracic outlet. So let's talk about that. So you've got nerves and vessels that go through something called the thoracic outlet in your shoulder. The walls of the thoracic outlet are made up by the scalenes. I don't know why that's happening with the pen right now. Well, anyway, we'll keep going. So those are the walls of the thoracic outlet. And then you've got the floor of the the roof of the thoracic outlet, which is going to be the clavicle, and the floor of the thoracic outlet, which is going to be that first rib. So you've got the walls as the scalenes of the thoracic outlet on either side. So the scalene muscle, and then the floor is going to be that rib. And then the roof is going to be the clavicle. And through that go nerves, arteries, and veins. So if the scalenes are tight, then that's going to cause compression of those nerve arteries and veins. That can cause numbness, tingling in the hand, lack of blood flow, etc. If the ribs come up too high, then that can cause the floor to close off that thoracic outlet. And if the clavicle is unstable, that you might see at the sternoclavicular or AC joint on either ends, that can also cause problems. So now you've got a sense of what that thoracic outlet is. And it's very common as a problem to see in patients who have any kind of neck issue, including CCI. Okay, so does anyone have any other questions for me to ask? Um, just reviewing backwards here. Any other questions I can answer at all? So to start reviewing what we were talking about, here was this idea of diagnostic accuracy and making sure that these measurements that we get, whether they be clivo-axial angle, C1, C2 overhang on DMX, BAI, BDI, translational BAI, translational BDI, understanding what the diagnostic accuracy of those measurements really is. And the only way to determine that, as we talked about, is a blinded study that puts people into a symptomatic bucket and an asymptomatic bucket. And we have to find out what level of that number correctly classifies people into the right bucket. Regrettably, for the neurosurgical measurements, I've not seen those studies. And again, if anyone out there who's watching has seen them, then by all means, please send them to me so I can go ahead and take a look at those. That's one of the reasons why we use DMX quite a bit, because that kind of research for DMX does exist. So that's why we do that. Ryan, do you think neurosymptoms, POTS, etc., are more related to CCI or the blood flow disruption from TOS? I have no additional TOS nerve symptoms. Yeah, normally neurosymptoms like POTS are more commonly considered to be due to CCI. So if we go to the website, which is the Regenix website, and we type in internal jugular, there's a good illustration on here. Oh, not that one. On this one that goes through really what we're talking about there, and that is that you see the internal jugular vein here. You've also got the glossopharyngeal nerve up in here, as well as the vagus nerve. And all of that's just in front of C1 and C2. And so commonly we'll see either C1 and or C2 putting pressure on this area. And if it puts pressure on the vagus nerve, that could cause POTS-like symptoms. So normally TOS is not generally considered related. Now, there is someone out there that believes that TOS could be related to some of these internal jugular vein issues that we see upstream in the neck. Could be. That person hasn't done this kind of study that we're talking about. So we'll see where that kind of thought goes over time. But right now, this is normally considered to be more related to CCI than TOS. Jeanette, having tried and failed to find a DMX machine in my country, Australia, I can only get an upright MRI and still one inflection extension. Jeanette, we do have a protocol for you to try to get a C1, C2 overhang measurement. So if you reach out to Carla in my office, she can provide you that protocol. And that protocol is not perfect, but it will give us at least some information about the side-to-side motion at C1, C2. And then, yes, certainly get what you can get, which would be a cervical flexion extension MRI, and happy to look at that. Ryan, I've also had right shoulder reconstruction after multiple extreme sports trauma. Yeah, Ryan, so in all likelihood, what we generally see in patients with that kind of history would be instability within the shoulder that's leading to the TOS. Now, also could be injuries in the neck as well, but most commonly we would see, for instance, instability at the sternoclavicular joint, the AC joint, the large shoulder joint, and that's usually what causes the TOS. And the solution is usually pretty simple, which is just tighten down those ligaments through injection. but obviously different in everyone. So I need to do an exam and look at all your images and all that good stuff. Ryan, I know the Internet Cowboy Larson has a hot take on this one. Yeah, listen, as I said last time, I think that guy has some really interesting outside the box thoughts, and he's apparently now going and getting a medical education, which is great because previously his only qualification was being a personal trainer. And we will see if he can produce some research that backs up that claim that thoracic outlet is related to a lot of these CCI type symptoms. I would say that it's more likely based on my clinical experience and actually being a medical doctor, and I've been gone through internship and residency and all that good stuff, that that the neck instability causes the thoracic outlet. But listen, I'd love to see some more research published by that guy. Diana, hi, Centeno, does the use of ECST, extracorporeal shockwave therapy, help ligament healing for CCI? Would you recommend we try it for acute injury-induced CCI? Probably not, simply because there's kind of no way to get there. And what I mean by that is that that's a shockwave therapy, and that shockwave therapy has to produce a shockwave that goes through to a certain point where the ligament lives. And the problem here is those ligaments are covered from the back. And while there is a small window for the ligaments at 0 between the skull and 1 from the back, your spinal cord's in the way. So any type of shockwave therapy that would be enough to treat those ligaments that deep is going to mess with your spinal cord. So that's a bad day for everybody. And then from the front, you just can't get there because it's covered by bones as well. So that's the problem here, is we're talking about ligaments that are covered deep in bones, 360. So you're just not going to get that stuff in there. And regrettably, part of your access will be blocked by the spinal cord and brainstem. And I don't think anyone wants to use a lot of ECT energy around structures like the spinal cord and brainstem. Nick, as far as CCI goes, at what point in time do you recommend seeking care at Center Schultz for providers in the Regenix network? I'm currently seeing a Regenix provider in the southern U.S. Yeah, Nick, a lot of that depends on what type of CCI you have. So I just gave the same example to someone who I was talking to today online during a telemedicine, and that was, if you've got things like C2-3, translational instability, inflection, then I think, some simple ligament work back here, perhaps treating the upper neck facet joints 0-1, 1-2, 2-3, or just 2-3 and the ligaments might help. If you've got atlanioaxial instability from side to side, not going to do much. That would require more of a PICL procedure, and there's no other clinic in our network outside of CSC that does that. So a lot just depends on what type of CCI you've got and what's causing the symptoms. Dana, does too much AO NUCA adjustments cause more instability? Not that I've seen, Diana. I think if we're talking about an acute injury that we're still trying to heal and someone kept messing with it in a very aggressive way, and neither AO or NUCA are that aggressive, then that could certainly cause some issues with healing. But I generally don't see that with AO and NUCA. Stacy, I have a fused spine T4 to L4 scoliosis. After 39 years, neck issues are getting worse. I do get my prolotherapy twice a year, occipitals to sacrum, but having pain issues worsening in my neck and occipitals, chiro massage and acupuncture help, but I can't seem to keep my adjustment. I sleep funny and wake up in pain. I used to go 2 weeks between treatments. Now it's once a week or more. Yeah, so Stacy, what you're describing is adjacent segment disease, and the problem is, I always tell patients that fusion is a dog with fleas. And what I mean by that is that it's an inelegant solution to the problem, meaning that we're making, in that case, large stretches of the spine not move at all, and that energy has to go someplace. So it's either going to go below, which in your case would be the SI joints, or above, which in your case is the neck. So that's the problem. So that we can't undo the fusion. Now, what we could do is to go to a higher level of treatment. So rather than prolotherapy, try PRP. Rather than PRP, try bone marrow concentrate. Rather than bone marrow concentrate, try culture expanded mesenchymal stem cells, et cetera, et cetera. That's the general idea. We could also inject other structures outside of the standard prolotherapy mix to see if that provides better prolonged relief. But I suspect that you're getting enough DMX that you're starting to, or I'm sorry, that you're getting enough ASD, that you're starting to have the proload not be able to keep up with all those extra forces and the slow damage that occurs. That's called adjacent segment disease with time. On DMX, my ADI is much worse than flexion. I just got a second posterior PRP treatment and I am flared up. Would my worse ADI and flexion explain why I have worse symptoms as I relax laying down on my back? Yeah, so just realize that when you're in flexion like this, what's happening there is you're hanging on the transverse ligament. And I think maybe I could show you guys that. So hopefully you can see this. This is C1 and C2 here, this way. And so we have here C1 and C2. So atlas and axis. And then these are bigger than normal. So there'd be a big skull on the top of this. Now, if you look inside, you can see those ligaments here. And we've got the alar ligaments on either side here. And then we've got the transverse ligament right here. And then this is the dens. So if you're looking down, what's going to happen is this atlas is going to want to push forward like that, opening your ADI, and you're hanging on your transverse ligament. The same thing will happen if you're lying face up on your back. Anything that pushes your head forward is going to push this atlas forward and put pressure on that transverse ligament and have the effect of opening the ADI. Now, there are active muscles that are going to try to oppose that, but the more relaxed you get lying face up, the worse it's going to probably be because you don't have those active muscles that are stabilizing there. So for instance, we'll see sometimes patients' ADIs open after we put them to sleep because they're in a slight flex position for the PICL. They looked fine when the patient was awake, but as soon as those muscles relax, boom, the ADI opens. So sort of the same thing with lying face up. Deanna, can we book our PRP and PICL if we qualify at our telemedicine consult? Yeah, that's certainly how this works. Again, we use all those different parts and pieces I've explained previously, looking at the imaging, we're looking at response to treatment, looking at the symptoms that someone has, how they got it, et cetera, et cetera. Assuming all those stars align, then yes, you can book a PICL from a telemedicine. There's the final piece, which is doing a hands-on physical exam. But it's pretty rare that once we get to that level of diagnostic certainty that we are completely surprised by what we're finding on exam, although it's possible. So yes, you can book it. Deanna, is your team releasing next analysis of the PICL outcome data in September? Yeah, good question. I think I told you guys I saw that about a month ago. I haven't seen it since, so I'm actually going to use this as an opportunity here, guys. Sorry to take a minute, but I just want to send our research director to give me a note to give me an update on the PICL data. Okay, thank you for reminding me. That just went out the door, and hopefully that'll prompt those guys to tell me when they're going to get that so I can let you guys know. Stacy, what if any diagnostic tests should be done to determine if or how much ligament detachment there is at a broken spinous process? Yeah, Stacy, I think we discussed that before. Really, the best thing to do would probably be an ultrasound in the office, simply because when we're doing an MRI, frequently the slice thickness is too thick to be able to really dial into what's going on with an individual spinous process. So we could get an MRI with a really thin slice thickness, but it's probably just easier to do an ultrasound in the office to see what's going on at that exact spot. Deanna, is it possible for our alar ligament laxity to heal somewhat, a rank decrease over 2 years? I know you said if by 6 months there's a little progress likely, ulcer ligaments can heal up to 2 years. That hasn't been our experience, Deanna. If you look at artificial ligament healing, so that would be mobile reconstruct injections, which is the research we've done and now published many times in the ACL and the knee, where we've got a big ligament where we can easily image it because we've got lots of MRI sequences that have been designed to see it well. In younger patients, we tend to see full healing at 3 months. In older patients, people in their 50s, that can take up to 9 months. So if we sort of split the difference between those two, not knowing your age, I would say 6 months is pretty safe. 2 years, I think what they might be talking about there is the extensive remodeling that might occur over time. But as far as getting to the point where we have a functional ligament, in young people, that's about 3 months, and middle-aged people about 6 months, and in older people about 9 months, based on the research that we've seen. Stacy, is Dr. Williams qualified to inject anterior lateral ligament tear, or should I wait for an XPICL with you? I think we're talking, Stacy, there about a ligament that would have to be hit from the front. So I don't think that would work with what Dr. Williams is currently doing. Deanna, why do you get a rocking on a boat feeling lying down with eyes closed? I always had head wobbling, but after x-rays now I get swaying boat sensation, feeling my head move in the pillow. Yeah, for the same reason that if you're on the deck of a cruise ship, you don't get sick, but when you go below decks, you get sick or nauseous. So what I mean by that, Deanna, is there are 3 different systems that provide information to our brain about head position and balance. One is the upper neck, the other is the eyes, and a third is the inner ear. Now, let's use our cruise ship example, right? We're on a cruise ship and we're above decks and we're looking at the horizon. So everything's in agreement. Our inner ear, the eyes, and the neck are all telling us that the world is slowly moving up and down. As we look at the horizon, that's all good because the horizon's moving up and down. Now we go below decks. If we go below decks, all of a sudden there's no more horizon, right? We can't look out. So now we have a mismatch. We've got the inner ear telling us that the world is moving slowly up and down, but we don't have a horizon to look at. In fact, everything we look at isn't moving at all to our eyes. So that's a mismatch that causes that. So in the same way, if you close your eyes, you're taking out the visual input component of those 3 systems. And you're getting a bigger mismatch between the bad information coming in from the upper neck and what the inner ear is saying. Patients will say the same thing if they try to walk to the bathroom at night. Their balance is far worse because they have very little visual input to balance because it's dark and they can't see much. So that's kind of why that happens. Stacy, is a PT recommended for neck instability? Very specific, only after a certain amount of healing has occurred. But yes, in general, it is. Paige, Centeno, last week I asked about enterolisthesis, C23. You mentioned a study and I can't find it. Do you mind sharing the name of the study? You mentioned the study shares one movement. Yeah, so that's the Lynn study. I'm going to try to find it here. I don't know if I can, Paige. I believe the guy's last name is Lynn. Flexion extension radiography. I think the journal was fine. I'm just going to type in a bunch of words in Google and see if it comes up. Let's see here. This could be it. I don't think this is the one I am thinking about. Yeah, so realize we have two different concepts here, though, right? One is now this is not a bad study to look at. So this is being recorded, so you can come back and find this one by, it looks like Wu, W-U. As far as Lynn, that's Penning's old study. So if you could, I'll put my email down here that goes to my desk, and send me an email and I'll try to find it for you. I have actually a PDF of it saved on the computer, so I can just send you that. But anyway, that would be a good one to start with, the one I showed you. And then, guys, I'm going to give you a 2-minute warning just because I do have to catch a plane. My brilliant assistant made this possible, but she kind of scrunched everything together to make it possible. So I'm going to have to get out of here in short order. Annie, how much is PANS formation a factor in not being able to reach transverse ligament? I'm 2 months post PICL number 1, doing great, by the way. Thank you. Schultz did not do my transverse ligament during PICL number 1, saying it been too much for my body, given my measurements and symptom profile. I'm excited for PS number 2. Yeah, it shouldn't be an issue. I think what Schultz was probably telling you, and I don't know your scenario, Annie, but that we have a below and above type of PICL. So I think he was talking about the below procedure, where it is easy to get into the bursa and the pannus. If we're coming from above, which usually we'll add in the second procedure, trying to make sure that we don't overload the person from the first, then more likely to get into both the upper alar, and if you go deep enough, you can get into the cruciate in general. So my overall sense is they'll probably be able to get there the second time. But again, I don't know your details. Oleg. Yeah, so the best thing to do there, Oleg, is to just upload them to Google Drive, upload the files, and send me the link. And then I had just put my email address that goes to my desk down there. I'll be happy to take a look at that. Tosca Donna, I have the rocking boat, room spinning feeling when I lie down too. Doing better since Dr. Centeno worked on me 6 weeks ago. Great to hear. But yeah, that's a common one. Yeah, hi, Dr. Centeno. Do you still have slots open for PRP and PICL for December? Can we join a cancellation list? Don't get treatment as soon as possible. Yeah, Deanna, that's something to reach out to Carla for, my assistant. I'm going to put her email down here, so you can just reach out to her directly. So ksalis@centenoschultz.com. I just typed it in there. So reach out to her directly, and she can go ahead and see what's available. I don't know offhand. She's the brilliant assistant that figured this out, so she's got the rest of my life figured out as well. So she will, my work life, go ahead and help you figure that out. We do cancellation lists all the time because obviously, especially these days, things happen. Okay, guys, it's 2:01, so I'm going to have to start wrapping this up because I do have to leave for the airport. Give a big thanks to Carla and shout out because she made this possible today. I wasn't going to do it because I was too concerned about getting the airport on time, but she arranged my entire day to make this happen. So thumbs up to Carla for doing that. And you guys have a wonderful weekend. Monday is Labor Day, so I think I'm going to take the day off. I don't usually get many days off. So I'm going to take it off, and we won't do this on Monday, but I will do it this coming Friday, giving a lecture on CCI to CBP Chiropractor Group in Nashville tomorrow morning. So hopefully we'll educate lots of chiropractors out there so they understand what's going on. So thanks so much, and have a great weekend, guys.